welcome to another episode of Clube da Cardio podcast, where science meets clinical practice and where physicians sharpen their edge. I'm your host, Dr. Pâmela Valelongo, a Brazilian cardiologist, and today we're exploring a topic that's changing how we assess volume status and venous congestion in critical care, VEXUS. This episode is a high-yield summary generated with the help of artificial intelligence based on a full conversation originally recorded in Portuguese with Dr. Rafael Hortêncio Melo, intensivist and a national reference in critical care. But here's something important. Every piece of content you hear today was curated, reviewed, and approved by our medical team at Clube da Cardio, because clinical excellence always comes first. From the ICU to the post-op setting, VEXUS is gaining ground. In this episode, you'll learn what VEXUS really is and how it works, its practical applications in clinical decision-making, pitfalls to avoid when interpreting the score, and why POCUS should be part of every residency curriculum in intensive care, emergency medicine, and cardiology. Let's dive in.
Welcome back to The Deep Dive. Today, we're tackling a tool that's sparking both excitement and quite a bit of confusion in critical care circles, the VEXUS score.
It's definitely a hot topic, yeah.
Yeah.
And as our source material, which is a great transcript from a recent expert podcast discussion, makes really clear, there's a need to cut through some common misunderstandings.
Absolutely. So our mission today in this deep dive is really to unpack VEXUS, but based only on what those experts were discussing. Think of this as your express route to understanding what VEXUS actually is.
Right.
You know, why it matters for patient care, especially kidneys, how you do it, its strengths, and also, crucially, some of its maybe surprising limitations. It feels a bit like the early days of CVP monitoring, doesn't it? You get lots of data, but figuring out what it really means, that's the challenge.
That's a very good analogy.
Yeah.
And that confusion, it often starts right at the basic concept.
Okay, let's jump in right there then, because the experts specifically called out this common mistake, right? Equating VEXUS just with hypervolemia, simply having too much fluid volume.
Yeah.
So what is VEXUS at its core if it's not just about volume?
That's probably the biggest misconception we need to clear up first. VEXUS is fundamentally, it's an ultrasonographic tool.
Okay.
It's designed to analyze venous flow patterns,
Okay.
specifically within what's often called the splenic circulation. So we're talking about key veins like the vena cava, the hepatic veins coming from the liver, the portal vein, and even those tiny renal interlobar veins inside the kidney.
So you're basically scanning these specific pipes, these veins.
Exactly. And what the altered patterns you see with ultrasound and Doppler actually reflect is increased intravenous pressure. The expert in our source discussion directly equates this to increased venous afterload.
Venous afterload. Okay, that immediately feels like a more, sophisticated concept than just fluid overload.
It is. And here's where the nuance from that source discussion becomes really important. This increased venous afterload, which VEXUS aims to quantify, it can be caused by many things, not just hypervolemia.
Right.
The experts listed several, and this list is key. You should think about, ventricular dysfunction, maybe a clot in the cava itself that's cava thrombosis, or even just increased pressure inside the chest cavity.
Oh, like from
From things like cardiac tamponade, maybe attention pneumothorax, or even really high levels of PEEP if someone's on a ventilator for, say, ARDS.
Wow, okay.
So while hypervolemia is definitely on that list, it's just one potential cause among others. They also noted that severe tricuspid regurgitation is a frequent culprit, often leading to a dilated cava and, very abnormal hepatic vein flow patterns.
That list really does underscore how VEXUS isn't just some simple too much fluid detector. It's looking at a consequence, this high venous pressure that has multiple potential drivers.
Precisely. And in a way, VEXUS isn't entirely new science. The expert discussion highlighted that the knowledge about different venous flow patterns, characteristic portal flow changes in heart failure, or how hepatic flow correlates with CVP, or those renal vein patterns, that stuff existed in the literature already.
Right.
The real innovation VEXUS brought was pulling these pieces together and packaging them into a practical bedside scoring system that you can apply fairly quickly.
Okay, so VEXUS helps us spot this increased venous pressure or afterload.
Yeah.
Why is that actually a problem? I mean, how does pressure building up on the venous side start causing organs, especially the kidneys, to malfunction?
Yeah, it comes down to a core physiological principle, basically.
Yeah.
Organ perfusion pressure.
Okay.
For blood to flow through an organ effectively, deliver oxygen and nutrients, there has to be a sufficient pressure gradient. We often focus a lot on the arterial side, like mean arterial pressure, the MAP, which drives blood into the organ.
Sure.
But the pressure on the venous side, which the blood needs to flow out against, that's equally critical.
Ah, okay. It's like pushing water through a pipe. The pressure at the start matters, but so does the pressure at the end it's pushing against.
Exactly that. As the experts simplified it, your organ perfusion pressure is roughly your arterial pressure minus your venous pressure. So conceptually, you can think of it like MAP minus CVP.
So if that venous pressure goes up, that critical pressure difference across the organ, it gets smaller.
That's the fundamental problem. If that pressure gradient across the organ's vascular bed narrows because the venous pressure is elevated, then the blood flow, and therefore the perfusion to that organ, gets compromised.
And the kidneys and the liver are particularly sensitive to this, you're saying?
Yes, that was a really key point from the source material. Encapsulated organs, like the kidney and the liver, they're especially vulnerable.
Why encapsulated?
Well, when venous pressure increases, it can cause pressure to build up within the organ itself in the interstitial space because that tough outer capsule kind of resists expansion.
I see.
This essentially squeezes the delicate tubules and sinusoids inside, further impeding flow and making the organ less tolerant to any reduction in that overall perfusion pressure. This mechanical effect, it really helps explain the strong link we see between venous congestion and developing acute kidney injury, or AKI.
This also feels directly relevant to the whole concept of fluid tolerance that we hear so much about now.
It ties in perfectly, yes. Fluid tolerance is basically assessing how well the patient's circulatory system, particularly the venous side, can accommodate additional fluid volume without causing organ dysfunction.
Okay.
So high VEXUS scores signal significant venous congestion, indicating fluid intolerance. And here's a critical, maybe counterintuitive point from the source. A patient can actually be fluid responsive, meaning their heart might pump out more blood if you give them fluid, but still be fluid intolerant.
How does that work?
Because that extra fluid just piles up on the venous side, worsening the congestion and ultimately hurting the organs. The experts mentioned a really striking statistic. 40% of ICU patients had some venous congestion just on admission.
40%? Wow.
Yeah. And fluid-responsive patients who also had venous congestion actually had a higher rate of AKI.
That really challenges the reflex to just give fluid because a cardiac output monitor says they're responsive.
That statistic alone is pretty sobering, definitely. Okay, so walk us through the practical side then. How is a VEXUS assessment actually performed at the bedside?
Right, so the process described in the source, it begins with the inferior vena cava, the IVC, and there's logic to this.
Okay.
The idea is if you see altered congested flow patterns downstream in the hepatic, portal, or renal veins, it only really makes sense to attribute that to generalized venous congestion if the IVC itself is also dilated. That suggests high central pressures.
Right, if the IVC is small and collapsing, exactly. Then those downstream findings might be due to some regional problem, not generalized congestion. So you check the main draining vein from the lower body first.
Makes sense. What's the usual order then?
The standard sequence they mentioned is IVC first. Then you look at the hepatic and portal veins. Often you can get those in the same window up in the upper right quadrant. And finally, the renal interlobar veins, though the experts readily admitted those can be the hardest ones to find and image well.
And you're using Doppler to actually see the flow.
That's right. You use pulse Doppler ultrasound over these veins. You're analyzing the flow patterns and specifically their degree of pulsatility.
Pulsatility?
Yeah, so the normal state is that venous flow becomes smoother, less pulsatile as you get further away from the heart. But increased venous pressure transmits those cardiac pulsations further downstream, making these more peripheral venous flows abnormally pulsatile, or sometimes even reversing them.
And you grade how abnormal that flow pattern is.
Yes, exactly. For each of the three systems, hepatic, portal, and renal interlobar, you assess the flow pattern, and you grade it as mild, moderate, or severe alteration. This is based on specific criteria mentioned in the source, like specific shapes of the hepatic vein waveform or the percentage variation in portal vein flow.
And these individual grades then feed into the overall VEXUS score?
Precisely. The VEXUS scoring system combines that initial IVC assessment with the most severe flow alterations you find anywhere else. So, VEXUS 0. The IVC is not dilated, basically end of story. Virtually no significant venous congestion by this metric.
Okay.
VEXUS 1. The IVC is dilated, but and this is key, you find no severe alterations in any of the hepatic, portal, or renal flow patterns.
Got it.
VEXUS 2. The IVC is dilated. You find one severe alteration in either the hepatic, portal, or renal veins. Just one system, VEXUS 3. The IVC is dilated, and you find severe alterations in 2 or more of the hepatic, portal, or renal systems. And the expert noted, if you already spot severe patterns in 2 systems, say hepatic and portal, your score is already a 3. You might save time by not needing to go hunting for those sometimes tricky renal veins.
That sounds like a pretty structured approach, but yeah, it also hints at the technical skill needed. Where in practice, drawing from the expert's own experience in the source, are they finding VEXUS most useful? Which patients?
They highlighted a couple of key areas in their own practice. Firstly, patients on cardiology services, or those admitted for significant cardiovascular issues, particularly patients with decompensated heart failure who have signs of congestion and multi-organ dysfunction, the classic cardiorenal syndrome patient.
That makes sense. It's the physiology we just discussed.
It does. But interestingly, they noted the patient population with the strongest evidence base, both from the original VEXUS study and their own meta-analysis, is actually post-operative cardiac surgery patients.
Oh, interesting. Why specifically that group?
They specifically mentioned checking VEXUS after the initial, say, 24-hour resuscitation window. The idea is that these patients often receive significant amounts of fluid during and immediately after surgery.
Right.
Checking VEXUS a bit later helps identify sort of occult venous congestion that might not be clinically obvious yet, but is actually a strong predictor for developing AKI a couple of days down the line. So it's used in a kind of predictive capacity there.
Like a proactive check.
Exactly. But the expert also mentioned using VEXUS more broadly in the optimization phase of resuscitation for pretty much any critically ill patient.
Oh, okay. Not just cardiac patients then.
Correct. Regardless of why they're in the ICU. During that phase where you're really trying to fine-tune resuscitation, they pair VEXUS assessment of fluid tolerance with traditional assessments of fluid responsiveness.
Okay, so here's the question then. If a patient looks fluid responsive on, say, a cardiac output monitor, but their VEXUS score is high, like 2 or 3, what do you do? Does responsiveness win out?
Well, based on the expert's description in the source, no. If the VEXUS score is high, even if the patient is technically fluid responsive, meaning a fluid bolus might transiently bump up their cardiac output, they are considered fluid intolerant.
Right.
Giving more volume in that specific scenario is likely to worsen organ congestion and potentially cause harm. So the expert said they would then prioritize other strategies, like maybe starting vasopressors, rather than just pushing more fluid. That approach really challenges some traditional fluid management paradigm.
It absolutely does. They also mentioned looking at the change in VEXUS over time, didn't they? Something called delta VEXUS.
Yes, exactly.
Yeah.
The source noted that at least one study suggested the change in VEXUS, say from day 1 to day 3, might actually be a better predictor of AKI than just a single static measurement.
That makes physiological sense, right? Are things getting better or worse?
Totally. And it follows logically. If you're treating suspected hypervolemic congestion, maybe you give diuretics or start ultrafiltration, checking VEXUS afterwards can potentially show you if you've actually improved those venous flow patterns. It becomes a monitoring tool for therapy.
You brought up the meta-analysis earlier. What does the formal evidence, like that study, actually show about VEXUS and its link to outcomes like AKI?
So the expert discussed their meta-analysis, which pooled data from 9 studies. It included 3 specifically in cardiac surgery and 6 in general ICU populations, covering just over 1,000 patients under 32 patients.
Okay, over 1,000 patients gives it a bit more weight.
It does. And the headline finding was that a VEXUS score of 2 or 3 was statistically significantly associated with an odds ratio greater than 2 for acute kidney injury in critically ill patients in general.
Okay, so higher VEXUS equals higher risk of AKI, basically.
Yes, that's the association shown. But, and this was a critical nuance the expert highlighted from the source, was the subgroup analysis. That association with AKI was extremely statistically significant and showed a very high odds ratio specifically in that post-operative cardiac surgery subgroup.
Ah, so the signal was much, much stronger in that particular group.
Much stronger, yeah. In the general ICU subgroup studies that were included, there was a tendency towards an association with AKI, but it actually did not reach statistical significance in their meta-analysis.
Why do you think there's that difference? Did the experts speculate on that?
They suggested a couple of likely reasons from the discussion. One, the studies in the general ICU groups might simply have been too small, not enough patients. to definitively detect the association statistically, even if it exists.
Okay.
And 2, the causes of AKI are just far more diverse in a general ICU population compared to the relatively focused issue of, say, postoperative fluid overload and congestion after cardiac surgery.
Those are fair points. So given that it's an observational meta-analysis, what was the experts' kind of bottom line takeaway on what we can confidently say about VEXUS based on this evidence?
They were quite careful to state that because it's observational data, it can't prove that VEXUS causes AKI, nor can it prove that specifically targeting the VEXUS score with therapy will definitely improve patient outcomes.
Right.
However, they concluded it provides relatively robust evidence that VEXUS is a reliable indicator of venous congestion, and that congestion is strongly associated with AKI risk, particularly following cardiac surgery. So it's like a strong signpost, but not necessarily a proven therapeutic target yet.
Indicator, not target. That feels like a really important distinction. Okay, let's pivot now to the challenges. What are the gotchas, the pitfalls, the situations where VEXUS might be misleading or just plain difficult to perform or interpret correctly?
Yeah, this section of the source discussion was particularly valuable, I thought. There are several significant pitfalls. The first one they really hammered home is regional alterations, meaning you can see patterns that look like VEXUS patterns, like a dilated cava or maybe pulsal portal flow, for reasons that have absolutely nothing to do with generalized high venous pressure or fluid overload.
Oh, that sounds like a major trap. Like what sort of things could cause that?
They gave some surprising examples, actually, like young, healthy individuals or athletes can sometimes naturally have dilated IVCs and even some pulsal portal flow.
Really?
Yeah. And then, more obviously, patients with cirrhosis and portal hypertension will have high portal pressures totally unrelated to cardiac issues. Also, patients with liver or kidney transplants, severe cor pulmonale, that's right, heart failure from lung disease, or significant tricuspid regurgitation can all show parts of the VEXUS pattern for specific localized reasons. And the experts stressed VEXUS hasn't really been validated in many of these specific populations.
So you could potentially get a VEXUS score of, say, 2 or 3, but it might be completely misinterpreting the underlying problem if you're not careful.
Precisely. And this leads to perhaps the single most crucial point the expert made, which is that VEXUS requires sophisticated clinical judgment, as they put it quite starkly, and I think this is worth quoting. The ultrasound machine has no brain. You have to use yours.
Oh, okay, fair enough.
You absolutely must integrate the VEXUS findings with the patient's entire clinical picture, their history, their physical exam, other data you have. Does this VEXUS finding actually make sense in the context of this specific patient? You cannot, absolutely cannot, treat the VEXUS score in isolation.
That's a really powerful cautionary note. What other challenges did they highlight in the discussion?
Well, technical difficulty is a big one. VEXUS is explicitly stated as not a basic ultrasound skill. It really demands dedicated training, lots of practice, and often mentorship to perform correctly, especially consistently finding and getting good quality Doppler signals from those renal interlobar veins.
Right, the tricky ones.
Exactly. And you need a quality ultrasound machine too, one capable of good pulse Doppler. It's not something you can just do reliably with any basic handheld device necessarily.
So it's not something you just pick up in an afternoon workshop then?
Definitely not. There are also interpretation challenges. The original VEXUS scoring was sort of intended to be subjective based on eyeballing the patterns.
Which is hard for learners.
Very hard for learners, exactly. And while quantitative measures exist, like pulsatility index, the original paper didn't recommend angle correction for Doppler, which can make those quantitative measurements unreliable anyway. And another major hurdle they pointed out, especially for getting accurate flow patterns in the hepatic veins, is that reliably analyzing the flow involves identifying different waves, the S&D waves, that correspond to the cardiac cycle. And doing that properly often requires ECG gating on the ultrasound machine.
Ah, okay.
Which can be difficult or even impossible if your machine doesn't have that feature, or perhaps more commonly, if the patient has an irregular heart rhythm like atrial fibrillation. That makes assessing the pattern very, very challenging.
Right. ECG gating adds a whole other layer of technical requirement and potential frustration.
It really does. And then there are the practical challenges of just time and continuity. Performing a full VEXUS assessment takes time, which, as you know, is always at a premium in a busy ICU.
Always.
And if only 1 or 2 people on a given rotation are actually trained and proficient in VEXUS, you might get a single snapshot, but you can't easily track changes over time, the delta VEXUS we talked about. And you potentially lose very valuable information about treatment response or disease progression.
And finally, those validation gaps we sort of touched on earlier.
The significant validation gaps.
Hmm.
While the evidence for AKI prediction in post-cardiac surgery patients seems relatively robust based on the meta-analysis, the utility and the proper interpretation of VEXUS in other patient groups like severe sepsis, ARDS, trauma patients, and so on, or for actively guiding therapy in really any group, those aspects are much less clear or simply haven't been proven yet by sufficient research.
So bringing all this into regular widespread practice sounds like it faces some significant hurdles beyond just the technical ones we discussed.
Absolutely. As the expert discussed, widespread adoption really requires substantial institutional investment in education and training. Doctors, residents, attendings, they need dedicated time to learn, to practice, and importantly, to get feedback from experienced users. It's a skill that needs to be cultivated properly.
And it sounds like just having access to the right equipment might also be a problem in some places.
That was highlighted as a major structural barrier.
Yeah.
Particularly in places like many ICUs in Brazil, which were mentioned in the source discussion, where ultrasound machines might be scarce or perhaps shared across multiple units. Point-of-care ultrasound really needs to be at the point of care, readily available whenever you need it.
And we really can't emphasize this enough, can we? It doesn't replace the bedside assessment or clinical thinking.
Exactly. VEXUS does not replace clinical judgment. Never. If you get a VEXUS score that completely contradicts your overall clinical assessment, like, say, a normal VEXUS, a 0, in someone who looks clinically severely congested, or maybe a high VEXUS in someone who seems dry and clamped down, you must step back and integrate all the information. The ultrasound finding is one piece of the puzzle, but it absolutely has to fit the whole picture. As the expert said, it just has to make sense clinically.
Looking ahead then, what are the big unanswered questions about VEXUS? What's the frontier for research in this area, according to the source?
The expert was very clear on what they saw as the biggest remaining gap in the evidence. We desperately need studies that show whether guiding therapy based on VEXUS, meaning, actively trying to lower a high VEXUS score using interventions like diuretics or ultrafiltration, actually translates into improved patient-centered hard outcomes.
Outcomes like survival or how long patients stay in the ICU, things like that.
Precisely. Does intervening based specifically on the VEXUS score actually reduce mortality? Does it decrease length of stay? Shorten ventilation time? Does it make a meaningful difference to the patient? They mentioned the ongoing Andromeda VEXUS trial as one example of research specifically designed to try and answer exactly this question by comparing VEXUS-guided resuscitation to standard care.
Okay, so it's really moving from using it for prediction towards testing it for intervention guidance.
Exactly. And this brings us right back to that core conceptual question the expert raised earlier. Is VEXUS primarily just a marker? Does it simply tell us the patient is congested and therefore at higher risk of AKI, kind of like how lactate tells us about tissue hypoxia, prompting us to look for the underlying cause? Or is it actually a target, something we should actively try to normalize, believing that reducing the score itself will directly improve outcomes? That distinction fundamentally changes how we would or should use this tool in everyday practice.
That distinction between marker and target feels absolutely huge. Okay, let's try to distill the key takeaways from this deep dive into VEXUS based purely on our source material.
Okay. Firstly, VEXUS is a sophisticated ultrasound tool. It assesses venous afterload, reflecting elevated intravenous pressure. It's not simply about overall volume status.
Right. And that increased venous pressure is physiologically linked to reduced organ perfusion, making encapsulated organs like the kidney particularly vulnerable, which helps explain its association with AKI.
Correct. The evidence discussed, particularly that meta-analysis, supports VEXUS 2 or 3 being associated with AKI, and that association seems especially strong and statistically significant in the post-cardiac surgery population, though we have to remember the evidence so far is observational.
But using it isn't straightforward.
Far from it, no. There are significant technical challenges in performing and interpreting VEXUS correctly. It requires dedicated training, a good machine, specific Doppler skills, and overcoming issues like needing ECG gating or finding those hard-to-get renal vein views.
And it definitely has crucial limitations we need to be aware of.
Absolutely. You can see VEXUS-like patterns for reasons other than generalized congestion, and there are significant gaps in its validation for many common patient groups, and, importantly, for guiding therapy.
And the bottom line is, it always needs to be put into context.
Yes. Absolutely. You must integrate VEXUS findings with the full clinical picture. Never, ever treat the score in isolation. Remember, the ultrasound machine doesn't have a brain. You need to use yours.
So here is a final provocative thought to leave you, the listener, with, building directly on that critical marker versus target discussion we just had. Given the demonstrated association between venous congestion, as measured by VEXUS, and organ dysfunction, how much should we really be willing to intervene solely to change the VEXUS pattern itself? And are we truly prepared for the potential consequences or side effects of those interventions?
That's a question that really gets to the heart of clinical decision-making, especially when faced with a new, powerful monitoring tool like this.
Indeed. Thank you for joining us for this deep dive.
Thanks for tuning into this special episode of the Clube da Cardio podcast. If you find this episode helpful, make sure to follow the podcast and don't forget to rate and review us if you listen on Apple Podcasts or Spotify. And here's something you don't want to miss. We'll be covering the European Cardiology Congress live from Madrid from August 29 to September 1st right here on podcast and on Instagram. Follow us for exclusive interviews, key takeaways, and the latest breakthrough in cardiology. See you in the next episode, and until then, keep practicing medicine with purpose.